can say this. UHC is anchored on primary health care. And it is a concept that needs to be unbundled further. Daktari here, I think, will add on, the Dr. Rai. But my position is, we operate now and plan for tomorrow, meaning that we have to exist now because the sick are there. The question should be, what does it mean that UHC is anchored on primary health care? It means that now we need to develop strategies in which we need to know how to reverse the pyramid. Take back the resources to the community. Now, and I'm going to now the specific question. If we are operating as a level 5 hospital, it means that cases that need can be tackled in level 4, and the level 5 services need now to take them there. So if you have specialists, for example, and you have hernia and the things that can be done in level 4 and they are not being done, it is the responsibility of level 5 to take now the resources there, supervise, strengthen those facilities, so then that the people from that area can access those services nearer home. In that way, they reduce the cost of services and increase, therefore, society's resources into the primary healthcare. Now, the responsibility of level 5 also should be now to take it back to health center. So that is the reversal system that should be tackled not in a dramatic way, but we need to start progressively now doing that. What we are doing now in Jaramogi, for example, we have mapped out. I usually give this example that the cases that we are seeing in special clinics, we know now that this number, for example, psychiatric. I give that example because I'm coming. The example of this area. 27% of psychiatric illness that access services, UTRH, 27% of them come from same sub-county. We've also mapped out what comes out from the other sub-counties, what comes out from other facilities that we are supporting. So that now we need, I'm using the word transporting specialists, reversing the making the referral system work. So the referral system means that not only are we referring patients vertically, but we are referring also personnel vertically, the parameters, and also the specimens. Once we do this, then we are saving resources. The resources that are saved are then now goes back to the community for the community interventions that Juliana was talking about. So eventually, therefore, UHC is meant to achieve primary health care. It's not a radical thing, but it's a progressive, purposive movement towards that.
Let me just add on to what my colleague has said. It's unfortunate that 27% of mad people come from my area. Do I look mad? I don't look mad. Anyway, it is something that needs to be sorted out. But I'll pick up from Dr. Luoch's word. That is, please call the nurses to the table. Have you ever given a dog a bone and there are other dogs around? What is the first reaction of that dog with the bone? It's straight. And if another dog comes near, they say, Life is like that. All people with a bone will never call you if your coming will interfere with this bone. You get what I'm trying to say? What I'm trying to say is that change will occur only when there is disruption. Mnakataa, si ndio? Mnafanya nini? Mnakataa. But you unakataa na reason. You have the power, you have the evidence, you have the logic, na mnakataa. Mkikataa, mnafanya kitu inaitwa petition. It's allowed in the Constitution. Petition with facts and go to where decisions are made and tell them tunataka kuketi hapa. Sawa? Na tunataka hii na hii na hii na hii. Lakini mkingoja ati mtu atakuinvite kwa table, mtangoja sana. So the entire change of the entire medical profession will come when you agitate for change with reason and facts. Sawa sawa? Mnakataa ati hii haitafanyika. Tumesikizana? Basi. Now she's asking me whether you go on strike for that. No, you petition with logic and reason. And by the way, the courts are also open. Just say you are dissatisfied with this thing and you want reason to prevail. Sawa sawa? Picketing is also part of the Constitution. Mkipenda mta picket. If somebody feels hot on the collar, they'll call you for discussion. Sawa sawa?
My question is, you only mentioned about what you are doing on maternal mortality. And we all know it is easier to audit maternal mortalities because there are very few. I'm not sure what you are innovating when it comes to the perinatal ones. More so, in looking at some of the factors, like we have an increase in the mortalities because of macerated stillbirths, and it has not been easy for us to follow these mothers to investigate and make a way forward when it comes to response. Maybe you share with us how you are managing the perinatals. Thank you.
Yes, Christine, you presented a paper on task shifting. I think somebody has tried to talk about that. I think it was a good presentation, coming at a time that probably I would say is needy, because I know NAK are trying to look at the schemes of service and maybe the scope of practice for nurses. And I think this would be interesting them in terms of the tasks and why they are being shifted and to who. Now, there has been two things that have been stagnating nursing in relation to that. The assumption of a nurse being a jack of all trade. And so they tend to assume to take tasks upon themselves, and others also assuming their tasks to be carried out by nurses. At this time, we know that when something bad happens, then a nurse is being blamed for having taken somebody else as a task. But when something good is happening, even though you are doing somebody else's task, things are fine because you're supposed to be a jack of all trade. So on that background, I think your study is coming at a good time. But my question is, therefore, how did you operationalize task shifting versus assumption of tasks? I didn't get that coming from you because it's a key thing so that we know exactly what you mean. Two, you talked of the qualitative part of your study was analyzed qualitatively, but I didn't get which objective of your which one of your objectives you are addressing qualitatively, because this would inform very necessarily for the nurses to narrate their story, to verbalize their feelings and their lived experiences in terms of shifting of tasks. So I think if you bring that out, this would be very, very important. Thank you.
To tie it up with the operational definition, because you say there is no policy. So it would be interesting to know what it is that you are really looking for and what you would use in this case, because you say there is no policy. So how do you operationalize that and then measure so that you are sure the tasks you're talking about are known, what it is that people are dealing with? Then Dr. Misore, I was just wondering what was the problem that informed your study? What really was? And then how are you going to measure? It was about what do we call them? How the people are able to deal with the issues of health. I'm not very sure how you're going to measure that, because what came out was what happens, they were poor, but the determinants, how you actually operationalized that, I didn't quite get it.
My question goes to Christine on issue of task shifting. There is a comment you made about rural urban distribution of health workers, and you say that urban is taking a lot of more skilled health workers as compared to the rural, especially those who are experienced in service delivery. So I didn't get you clearly on how this task are going to be shared to these inexperienced guys that are being distributed in the rural areas, while experienced guys, they run to town where there is a lot of resources and a lot of good infrastructure in care. Thank you.
Actually, not a question, but let's say action points on what Clara was presenting. That was on uptake of MPDSR. And I have 3 points in which I believe it's good all of us take it home. Point number 1 is let's try and scale up the training and scale up training of emergency obstetric and newborn care countrywide. That is, let's go back home. As you've heard, Clara was one of the persons trained on as an assessor of MPDSR. Let's also make sure one of us from our counties is trained or takes part in the auditing and maybe taking back the reports on this MPDSR, so that we can end up improving the feedback and pointing out the indicators that you can make some changes on. Number 2, we thank the government through Margaret Kenyatta, First Lady, that is by introducing the Linda Mama and free maternity services. Through this, we eliminate the user fees, and mothers are able to access health care. That is, now there are those obstacles that cause the maternal prenatal deaths. Through this elimination of user fees, we get that we'll be able to access the health services and prevent maybe the avoidable causes of death. The last thing will be instituting maternal and prenatal death surveillance and response mechanism. Let it be in our facilities. I think
Not
that's
a question, but just a concern to Mr. Macau on the night shift. I would wish to clarify that nursing being 24/7, the nurses can not only work when the sun is shining, but they can also work when the sun has set down. That one means that the shifts needs to be regulated such that when you are on a day shift and a night shift, you are still on duty as a professional nurse. So there may be some of the issues which may not arise, and this one needs to be incorporated early in training as it starts. And I'm sorry that in University of Nairobi, the students are not conversant of their expectations as qualified nurses. And that one may bring a problem in the practice, like the ones we are experiencing. When you are on night duty, it means your sleeping patterns only changes. That you are supposed to sleep in the day and work in the night. And not to work day and night, and then you go and you become fatigued and you are not able to work. The issues of litigation we have been having, like that one we had in some hospital in Athi River, is not befitting a profession like the one of nursing. And we really need to wake up and appreciate the profession we are in. So maybe take that one back home and tell them, when you are in here, night duty is mandatory, not complimentary. And I would say also that my concern also is to the maternal audit, that is for carriage. And I would say that maternal audit issues, that one is in the neonatal and maternal mortality issues. There is collaborative service or approach where many medical team members are participating towards the positive output of the service which we are offering. But the nurse is in the lead position because we are the ones who are with the patients for a long time, or with the mothers and the children for a long time in the nursery, at the same time in the maternity. And that one means that we have to take a very great assertive role to know our scope of practice and to implement. So when you implement what is right and call, I remember we advocated that this issue of calling the doctors that they are on call and sleeping in their homes, I hope ended. And if it has not ended, those nurses in referral hospitals, can you take the lead to end it? The doctors are on duty, everybody's on duty, let them be on duty that time, because they also get offs. So they don't need to go and sleep, then they are called. Only 30 minutes or 5 minutes in a life of a mother and a child can bring the mortality. But when they come, it's the nurse who is having the problem, not them who didn't come on time. So can we take up our roles correctly? Thank you.
Allow me to respond to more than just my questions. I'll start with the lady who says that the task shifting talk makes her sick. I do apologize about that. And the fact that I made it sound sweet. I think at one time I said that there are proponents and opponents to task shifting. It is not 100% having advantages only. It also has disadvantages. Some of them could even be quality of healthcare. Like I showed in one of the tables that there were people who are getting tasks shifted to them before they either had been trained or before they had been mentored. That, of course, is a problem. Then we have professional protectionism, which we must really protect our profession. But looking at how long we have been protecting our profession, and yet patients are still dying there out in the community without anyone looking at them, that's why I chose to look at the side of the advantage. I am privy to the disadvantages as well, but when you compare the disadvantages with the advantages, you find that the weight is falling more on the advantage side. But of course, also the law matters. The law of our country and what we have agreed upon as an ethical standard also matters in what we do on a day-to-day basis. It is true that lots of our nurses are unemployed, and when, as a country, we need to ask ourselves, why are we task shifting when we have qualified nurses out there who do not have a job? Is it cheaper to task shift, or what is it that is causing us? We need to be on the decision table, and I think we said that from yesterday, so that when we are deciding whether to embrace task shifting or not, we are there and we are actively participating and owning the process from the inception even up to the end. And that way we will be in the picture of why we are taking it or not taking it. One thing is sure, that if we take task shifting, in some places it may apply and some places it may not apply. Just like we heard this morning from the lawyer that we have regulations that are only specific to specific counties, depending on the needs that the people in that place have. And therefore, task shifting may not be a countrywide thing, depends on the decision makers. Who will decide which way we go. And definitely somebody said that citizens need quality health care, and that's a sure thing. Looking at universal health care from yesterday, we've been told about quality. Regardless of the fact that we are aiming at reaching out to everyone, we need to give everyone quality health care. Professional health care needs to go to everyone, whether they can afford it or not. And then the third thing, other than access and quality, the other thing is financial protection when it comes to universal health care. Therefore, we really must think critically. Someone has said that, and I support that. Citizens' money, somebody commented about citizens' money and corruption, and we need to close gaps, and it all starts with me. What are we doing in the family? Corruption actually begins at home. The corruption in this nation began in our homes. When I was a child, maybe I would be sent to buy sugar, and I bring the change 1 shilling less, and pretend maybe a shilling got lost or something, yet I've just bought a sweet. So we need to begin at the individual, move to the family, move to the community, move to the institutions, and fight corruption at all levels. So that this way we can close those gaps that are at the level or national level. The other question that I would like to touch on is someone talks about 2 assumptions of task shifting. That the assumption that the nurse is a jack of all trades, that has been the argument for a long time, and some people still have that mentality, that if a job in the hospital has no one that is allocated to, it is expected that the nurse does it. If the cleaner doesn't come, or if the nutritionist doesn't come, if you're at that level of institution, then the nurse is supposed to take that. I think what brought this issue is the fact that we are the patient's advocate, and therefore we don't like to see gaps in the care of the patient. And therefore it made us, even on our own part, without anybody allocating us to do those duties, we used to find ourselves just closing those gaps in the healthcare. If it sounded like task shifting is going to make the nurse to become the jack of all trade, that is not what it is. But in some of the evidences that are published, you find that when it came to cross-cadre task shifting, the nurse would get everything task shift to them. But let me ask you a question that was asked here either this morning or yesterday. We keep complaining about the non-nursing duties, even in my own institution. But when you ask nurses to write down the non-nursing duties, they don't come out to write them. The other thing, without having the nursing process in place, if we are not doing nursing process, what we are practicing as nurses is not professional. And therefore, we need to go professional even as we handle the other things. Operationalizing and assumptions of task shifting, we just picked the WHO definition. Then we looked at the scope of our practice and the job description of the people. We had a checklist, a questionnaire, a key informant interview, and a focus group discussion tool. So, which questions were qualitative? It is the objective that was looking at the experiences. That was qualitative. And then for every question, we also were giving an opening for open comments. So task shifting role in the rural area, it is the role that would be taken by the qualified person. Just the way it flows, it wouldn't be any unique in any way. Just the same way, a more qualified person task shifts to a low qualified person, and they take the more technical work for them. Allow me to say something about night duty. Night duty, when you read about it, it touches on the circadian rhythm. Each one of us seated here, we have a different circadian rhythm. Those who have a longer circadian rhythm, they take night duty better. There are nurses who have actually asked to go on night duty, and they do better, while others really struggle. And therefore, the effects are known and they are scientific. And fatigue is one of the things. Medical errors is one of the things that is common with night duty. And therefore, the people who have a shorter circadian rhythm tend to be more dissatisfied with night duty, as opposed to those who have a longer circadian rhythm. Thank you.
We are going to be very specific. 1 minute, please, because we don't want to be here the whole day.
Okay, good afternoon again. I had two. one comment and a question. Somebody from Kakamega wanted to know what we are doing for management of the perinatal deaths. If you work in the public hospital, I believe you've realized that currently we are using a soft copy from the DHIS. We upload all our perinatal deaths and audit them we are supposed to upload in the DHIS. And currently for us, we have a dexamethasone research, and we are breaking the very low birth weights from the perinatal deaths. For more, just see me, I'll explain further. And for MPDSR collaborating and for us taking up our roles, that we are doing it. 24/7 role of calling the doctor, I was very specific that we innovated with the teaching institution that we have the gaps, that issue of calling the doctor, we now have an obstetrician on a 24/7 because we've collaborated. That is our innovation. And also for the students taking up their role, remember you teach them in class, and we have a role in mentoring them aspects of the hidden curriculum. That's why we mentor them, and formally and informally. And I think that is all I had. And just to back up and to support my brother on the night duty issue and University of Nairobi, some curriculums and some institutions, policies that are loaded in curriculum development, they don't allow their students to work on night. BSNs have some period of internship, but the generic diploma students, they don't have time for. So an assumption is that after their training, they will go for an internship and they'll take up night duty. Probably that informed Nairobi University and other institutions. Thank you.
I also had two questions. One was what do we do with malnutrition? Now, if we had a good community health system working, first of all, you'd be able to identify in the Road to Health card during your MCH services that the weights of the children are going down. From that, you're supposed to be able to take it up and find out what is happening at the household level. And it is normally linked very closely with food insecurity. If you are able to establish that, then we are now able to collaborate with other sectors. You may have short-term, where you can give supplements, long-term and supplements and education. Long-term, then you may need to involve another ministry, like the Ministry of Livestock and Agriculture, to be able to support those kind of communities at that particular time. So what we are trying to say in short here, that our community health structure is not working. Yeah, sometimes we may be able to identify that, but you're not able to go to the household level to link or to establish what is really happening at that household level. For the second question, the problem again here was the community structures and systems. And we said that the community, for a community to operate, because we have community-based organizations, and we said they are both formal and informal. Formal in that most of the time they are registered. Informal, they are not they don't operate as a formal institution because you are not able to regulate them, you are not able to pay them, you are also not able to actually supervise them. Because if they don't work, it is voluntary. What are you going to do about it? So it's what we were saying, that we need to have policies, systems, and structures that are able to legalize and operate community services. And we were looking at these community capacities against access to the social determinants of health, which is food, safe, clean water and environment, access to health, education, income, and social capital. And from the findings of the study, there was a very clear correlation in that because the communities were not able to access these social determinants of health, it actually caused morbidities amongst these children. And we could see the morbidities were quite high. And that included upper respiratory tract infection, malnutrition, malaria, and diarrheal diseases.
I want to thank all for the 2 questions, or rather concerns, and also to thank my colleagues for their support. Maybe they have answered 1 or 2 things I needed to say. So the first concern was about clarifying what I meant by nursing is 24/7. I did not mean that a nurse should work 24/7, but I meant that at any particular time in the day, throughout the week, throughout the month, you will not miss nursing care being offered. I hope I am clear up to there. And just a small concern which my senior colleague brought up is that sometimes we find that people are on night duty, and instead of during the daytime now changing their sleep pattern, during the daytime they go and start doing locums in other hospitals. You find that is a major challenge which we are facing, basically because of the economic times. I hope I have answered that. The last concern was about the job dissatisfaction. It's not that the nurses are not proud to be nurses, but you find that the working conditions make them rather to say they are not enjoying what they are doing because of the work condition. One, because you will bear me witness that for night duty it is longer than any other duty. Sure. And then you find that you are working against the natural order, because you are, as a human being, you are created the day to work, for night to sleep. So it is against the natural order. And then you find that there are some few benefits which the day shift nurses enjoy during their work. Basically, I can quote basically the trainings, the CMEs, you find them, they are being conducted between 8 to 9, around that time morning. And when you gain 1 or 2 things about, you add on to what you know, is somehow satisfying, but you'll never find a CME which is being conducted in the night. So some of the benefits which the day or the morning, afternoon shift nurses enjoy, the nurses during the night do not enjoy. Thank you.